Now let us move on to developing a good patient approach by the talk by Dr. Gopal S. Pillai. Over to you, Gopal.
Thank you very much, sir. All the education and all the skills that we are developing is basically meant for the patient finally. So developing a good patient approach is one of the most important things that all our postgraduates should be looking at. So I put in some 12 commandments like patient is supreme, observation, lend your ears, thorough history, activities of daily living, proper examination, dialogue and discussion with the patient, educate with simple diagrams, sugarcoat bad prognosis, honesty is the best policy, and aggressive patient, how are you going to manage, and how to break monotony and be yourself. So let's talk about one by one. Patient is supreme always. That is something that we have to have in our mind. We are not supreme. In the hospital, between 9 to 5 or whatever is your work timing, patient is supreme. Right from reception to the OR, he is the supreme person. Patient over personal life, personal times of all the staff and doctor in that particular time when you are in job. Outside working hours, it's your choice. Like some people still give mobile numbers to for the patient to infringe into personal time. Some people don't. They are all your choice. But the patient should have the perception that he is being taken care of nicely. And that perception comes if you honestly try to do that. Second thing is about observation. Okay? Right from arrival of the patient to when he comes into our room, when he goes out, you have to keep on observing the patients. You will get subtle clues. Your staff can communicate to you. Like many staff will come and tell, there is one chori patient who has come. So the chori patient is a chori because of a reason. Okay? And we have to manage that reason. Because that is what the patient wants finally. It is not about diagnosing one particular. Finally, what has happened is, we have all moved into diagnosing a disease and treating a disease. Whereas, like William Osler said, you have to treat the person. You treat the disease, you may win, you may lose. But if you treat the person, you definitely win. Whatever happens to the end of the disease, you win always. So expectation reality mismatch is basically caused by the patient thinking that he or she is not heard about. So what is a diagnosis? So one important thing that I do generally is, the patient is sitting outside. I'll just guess, okay, what is the diagnosis of this patient? That gives a little mental exercise, which gives you a little bit of, like if that, like for example, a 75, 80-year-old person is sitting outside, it may be AMD for me, whereas it may be something else for a glaucoma person. So in front of my OPD, 80-year-old person versus 40-year-old person, I can guess my diagnosis, which may give me a thing. Now, lend your ears. Okay, patients come to talk. There is definitely an organic problem with a lot of patients, but there is also a functional component. The functional component may be larger in a lot of patients. You will diagnose in 1 second, no doubt, because we are in ophthalmology, the eye is completely transparent. If it is a macular hole or a diabetic retinopathy or a cataract or a glaucoma, you will diagnose in a second. But the patient needs to be heard. He will be telling that, in the morning when he gets up, there will be some blurring of vision when he looks to the right side up, because that is a place where the clock is. You need to hear that. Be patient and hear that. And patient needs to get up after the patient's needs are over. Don't have to hurry them out. Proper history. Usually we ask them for a 5-second history, but a proper history gives us the etiological diagnosis. We need to know about that. Examination gives us the anatomical diagnosis. Proper history is very, very, very important, which is what gets you closer to the patient. Always we should look at activity of daily living. What does the patient do now versus what does he want to do? And is the disease the cause of decrease of ADL? And if I remove the disease, like for example, you put the disease as cataract. If I remove the cataract, will the patient be able to do the activities of daily living that he wants to do, which he is not able to do now because of the cataract? That is what we need to look at. Proper examination, complete examination. You have to take some time for examination because otherwise the patient will go unsatisfied. And we have to tell the patient how each of these aspects of examination is actually going to benefit him. Immediately after the clinical examination, you have formed a mental impression of the diagnosis. Patient is also very anxious to know. This is a point of time where you can actually put forth a DD. Be honest. If you don't know, say you don't know. We'll look at it. We'll find out. And a simple diagram-based discussion is very, very good. And next step is to tell him what investigations are good. Education of patient is very important. Unless the patient is educated, he cannot understand the nuances of management, what you are talking about, what investigations you are talking about. So education of the patient is a very, very important step. Now, management nuances. Obviously, there will be multiple ways to manage any patient. There are different ways to skin the cat. But, you can talk about pros and cons of the management system, injection versus laser versus observation, all those things. But don't completely confuse the patient. If you confuse the patient, he doesn't get a final decision as to what is to be done. You have to do your mental calculations as to, if I am the patient or if my father is the patient, what am I going to do for that patient? And then look into his eyes and tell him that this is what I am going to do for him, even though there are a lot of approaches. If there is a bad prognosis, generally try to sugarcoat it. I mean, you can tell them the approximate diagnosis, but don't have to be very, very, like for example, an engineering student who was diagnosed to have RP, committed suicide the same night. So that is the problem of breaking bad prognosis, just like that. Aggressive patient management is a very difficult thing. It is a talk by itself, but let me just tell you, if I have about 1 minute, there are 3 levels of communication. One is up here, one is middle, and one is lower. When the patient is up here and aggressive, you can't be aggressive right away. You have to be here. You have to be receptive. You have to hear him. And then slowly, he will also mellow down. You can also come up. That slowly stepwise approach is important, and then you can have a brotherly conversation. First is, as the father would scold a son, you have to hear it. And then you have to move down to a brotherly level. And then slowly you can be more aggressive and tell that the disease is taken care. That is the way. If they go the physical way, you need to probably move out, and bouncers may be the future. People are standing outside our door also. How will we beat monotony? So all this will create a lot of monotony in our mind. And that monotony has to be broken, otherwise you are completely bored to death. So what is unique about each patient who is sitting in with me? And what are the features that makes this diagnosis a little different from all the other diagnoses of this particular disease? Think intelligently. That gives you an insight. What is the difference in the management nuances between this particular patient versus the other patients with the same disease? Is this patient reportable? Could I have done better in him? If you answer all this, probably you can be beating the monotony. So becoming a good ophthalmologist requires not just knowledge, attitude, aptitude, and cultivating skills, but good communication, and use your knowledge, aptitude, attitude, and skills to communicate the patient. And reading makes half a man, writing makes a full man. Conference where you interact and you are asked a question and you answer to the question makes a ready man. Discuss with peers. Thank you very much.
Thank you, Gopal, for saying what need to be said in 60 minutes in 6 minutes or 7 minutes. Everybody seems to be quoting Dr. Osler. I too want to say something. Dr. Osler has said, good doctor should be available, affordable, and affable. Nowadays, availability and affordability may not be much of a problem, but affability still remains the prime thing in patient management. Listen to his complaint and explain well. Thank you. Now,
it was a really good talk by Dr. Gopal. Just I would like to highlight 1 or 2 points quickly. That many of the patients, our ophthalmology patients, are having chronic diseases, diabetic retinopathy. Once they start, they have to have a lifelong follow-up. There's also open-angle glaucoma. Such cases, I feel it is better that we have a responsible bystander also to come with him during the next visit, so that they can be entrusted with they also will come to know how far, how frequently the follow-up has to be. Otherwise, most of the patients, when they come to me, I ask the bystander also to come inside the room and counsel them or advise them more than what I tell the patient, so that they will be responsible for the follow-up.